Hello guys, sorry for this small delay. We'll start our lecture in 2 minutes. Please take 2 more minutes and we'll start from the amino acid degradation and synthesis. Okay, so you saw the lights off. It means that our lecture is already on. Life science, 3 amino acid degradation and synthesis. If I remember correctly, previous week we started amino acid degradation and synthesis, this topic, and we were able to cover a couple of amino acids. Am I right? Good. We talked about glucogenic and ketogenic amino acids. We talked about different characteristics and conversion of specialized amino group. We talked about asparagine conversion into aspartate, and from aspartate, how are we going to get oxaloacetate? Since oxaloacetate will participate in a gluconeogenic pathway that can give us glucose. That's why it's called glucogenic, and there were a couple of other examples. If I remember correctly, we were not able to finish. We talked about SAM, hydrolysis, homocysteine and vascular diseases. I hope you already remember about that. We were able to cover it to some degree. I was not able to cover leucine, isoleucine, valine, right? These 3 amino acids, leucine, isoleucine, valine, has something specific in themselves, and these specificity, 3 amino acids that have the same specificity, is their shape. They have branched chain. We are talking about the side chain, right? You know that amino acids have the same COH group, COH group, have the same NH3 group, same 1, 2, 1 carbon inside, and side chain. This side chain is something that is specific about each particular amino acid. Okay, I hope it will work better. So the side chain is something that makes the amino acid as we call it, as we know them, special and specific. Isoleucine, leucine, valine. These 3 amino acids should be discussed together because their side chain has some specificity that is typical for only these 3. First of all these 3 are essential amino acids, right? I hope you remember about those. All 3 are essential. It means we need to take them with the diet. And body do not have the ability to create these amino acids de novo. So body do not have the ability to create it from another compound or by transforming another amino acid. For example, another example, tyrosine is an amino acid that we call non-essential. But to get tyrosine, we need phenylalanine because phenylalanine can be converted into tyrosine. There is a teeny tiny difference between their molecular formula. Teeny tiny 1 hydroxy group on the side, and that's it. From phenylalanine you get tyrosine. Phenylalanine itself is an essential amino acid. It means that we have to take it with the diet. We need to take it with food and then convert it into different compounds. This another compound is already non-essential. But if you think about it, even non-essential amino acids depend on essential amino acids. Similarly, slightly different is for isoleucine, leucine, valine. They are not converted into anything they are not converted to have this initial form. Initial form is derived from the diet. Okay, that's something specific about it. Specific about the side chain is their branch chain. I will show you molecular formula of these three, and they have kind of a branching, and this branching makes them special for degradation. You know that amino acid can convert into another compound or it can be degraded. All amino acids in the end should be degraded or converted into some other substrates that we can use it, so it should leave patient body. These three amino acids are special because they need special sets of enzymes to get degraded that we call branch chain amino acid dehydrogenase, and they have special. These are complex. It's not just one easy enzyme, but we don't go into specificity. The problem is that there is a known deficiency of the enzyme, so this enzyme can at some point can be deficient in inside the patient from the very beginning. So from childhood or in fetal stage, if this enzyme is not present, it will not be present ever. That is called metabolic disorder or metabolic error or error in a metabolic pathway. Degradation of brain chain amino acids that we call maple syrup urine disease. I think we mentioned that in previous lecture as well as an example of something special and specific about amino acids. Okay, that can happen as a disorder, and we will talk about this disorder, I think, in the end of the lecture more. But what can we get from the leucine? And is it ketogenic or glucogenic? First of all, leucine is exclusively ketogenic. That means that from leucine we cannot get glucogenic pathway. It cannot participate in gluconeogenesis. It will participate in ketogenesis. So it cannot form oxaloacetate, for example, because oxaloacetate is a part of gluconeogenic pathway. But on the other hand, ketogenic pathway means that leucine. I can't show you. Sorry. That's better. It means that leucine can give us acetylcholine and acetoacetate. That is how and that is why it participates in not in gluconeogenic but in ketogenic pathway. An initial step of the leucine is very similar to all the other isoleucine and valine conversion. Because these three are kind of similar to each other, when we are talking about one, it means that another two has more or less similar pathway with a teeny tiny difference that we don't even pay that much attention. But isoleucine itself is, compared to leucine, slightly different, so you can remember it with the name isoleucine. Iso has something different. Isoleucine is ketogenic and glucogenic. Why it's so important? We can get acetyl-CoA and propionyl-CoA as well from isoleucine. We cannot get it from leucine. Steps are similar to valine and the leucine. What about lysine? What is special about lysine? Again, lysine is a ketogenic amino acid, and it's an exclusively ketogenic amino acid. And lysine will be converted into acetyl-CoA. That is specific about lysine. Would be nice if you remember that lysine is exclusively ketogenic, that lysine can give us acetyl-CoA. Tryptophan, amino acid that probably you heard a lot and probably you will hear a lot later. Why tryptophan is so important? First of all, tryptophan can participate in both pathways, so it can give us it can be glucogenic or ketogenic, and it can give us alanine or acetoacetyl-CoA. That's the important one. Tryptophan, later we will talk about it more, is a precursor for different neurotransmitter. And if there is a problem with tryptophan conversion or deficiency of tryptophan, then we are facing disorder. And this disorder is important for you to know. Just try to keep an eye on that. A branched-chain amino acid catabolism is isoleucine, leucine, valine. Initially is the same. And catabolism of these branched chains can happen inside the skeletal muscle because skeletal muscles are using those branched chain amino acids for building up the proteins, or inside the liver. But mostly skeletal muscle rather than the liver. Sets of reactions that should amino acid go through. The sets of reactions start with transamination. As the name implies, transamination, what does that mean? Yes, transferring amino group from one compound to another compound. So whenever we are talking about transamination, we are not talking about just cutting off or lysis of the substrate or removal of the amino group completely and getting into trash bin, let's say. No. Transamination reaction means that you take this amino group from one compound and attach it to another compound. It means that for transamination reaction, it's not just one molecule that's involved to cut it off, let's say, but you need two different structures. From one, you take amino group and you attach this amino group to another compound. That makes the very idea of transamination. We have three amino acids. These branched chain that are catalyzed by the same enzyme, and this same enzyme requires vitamin B6. I think we haven't talked about vitamins yet, and not in the second semester. Vitamins are a very important part of the biochemistry, and we will discuss a lot of vitamins. But right now, let's try to remember enzymes and their cofactors, in which vitamin is a cofactor for a special enzyme. So here we are in transamination reactions, we are talking about vitamin B6. It's important to remember vitamin as a cofactors and coenzymes, since their deficiencies may alter the pathway and patient will suffer different disorders or different complications. So whenever there is a linked disorder or linked abnormality, it means that we have to remember this pathway. That's why I'm underlying this vitamin B6 and transamination reaction, because it can be problematic later in your patient. It is necessary for transamination reaction of a branched chain amino acid, these three together. Next step of the conversion of branched chain amino acid is oxidative decarboxylation. Again, as name tells you perfectly well, it's an oxidative because oxygen is involved, and decarboxylation means removal of carboxyl group. Oxidative decarboxylation. This carboxyl group is not transferred to anything, but it's rather removed, and alpha keto acid is formed. So leucine, isoleucine, valine after oxidative decarboxylation will give us alpha keto acid. Please try to remember these alpha keto acids that are coming from isoleucine, leucine, valine, so from branched chain amino acid, because it's important. It will play a significant role in the disease. If there is a problem of this pathway, branched chain transformation of branched chain amino acids, then something will accumulate, and this something that accumulates is the major culprit of the disorder. This is alpha keto acids. So it's a middle. It's not a final step, of course. It's not initial step, but it's an intermediate product. So if you do not continue this pathway from branched chain amino acid, the oxidative decarboxylation, if you don't continue from this point on, then these alpha keto acids will accumulate, and this accumulation will cause severe problem. Severe problem, first of all, is acidification of the blood. So patient blood will get acidotic, And the acidosis is the major issue because acidosis in the brain will interfere with the brain function, with the axonal transmission, so patient will develop mental abnormalities or the retardation, mental retardation most importantly. Don't forget, when we are talking about metabolic disorders, like inborn errors of metabolic disorders, we are mostly talking about children, neonates, toddlers, so young age. Does not mean that metabolic problems will not happen later in life, but in majority of cases, we are talking about young children. And right now, again, we are talking about newborn patients who have branched-chain amino acid degradation problems. Why it's a problem? You can see one step here. Accumulation of alpha keto acids. That could be the problem if we stop here and not continue from oxidative decarboxylation in the upper steps. What does the oxidative decarboxylation step needs to continue this process? After we get alpha keto acids, we need dehydrogenase complex, and this dehydrogenase complex is a complicated enzyme, very complicated, and it's similar to other dehydrogenases. We covered a couple of dehydrogenases before, if I remember correctly. Yes, so a couple of dehydrogenases were covered. It's not all. We'll talk about other dehydrogenases, but they have something similar, and the similarity is the cofactors and coenzyme they need. The complex branched-chain amino acid dehydrogenase or alpha keto acid dehydrogenase will need thiamine pyrophosphate, lipoic acid, FAD or FAD, NAD plus coenzyme. So, CoA. So it's similar to, maybe you've heard about this abbreviation, but similar to tender loving care for Nancy enzymes. I think we talked about it, tender loving care for Nancy. If I mention this tender loving care for Nancy, it does not make any sense, right? It does not make any sense, but it's an easy mnemonics, easy way for, not abbreviation, but mnemonics, easy way for you to memorize and not to forget what this alpha keto acid dehydrogenase complex needs to work. Because it's not just one B6, right? Previously, we just mentioned one vitamin B6 and that's it. Here it's a multiple factors, cofactors that's necessary for the dehydrogenase complex to work. It's a complicated enzyme, very complicated enzyme. But for it to work properly, we need tender, stands for thiamine pyrophosphate. Loving stands for lipoic acid. Care stands for CoA. Loving care 4 stands for FAD. Nancy stands for NAD. So maybe it can help you to memorize it better, since you need to memorize that. So if you ask me what exactly do you need to memorize, everything we covered so far. I haven't mentioned anything extra that you can skip. Everything is mentioned is necessary for us to memorize. Okay. And if patient is having disorder of branched-chain amino acid transformation, this disorder will be specifically linked to the alpha keto acid dehydrogenase complex, some kind of an abnormality with this complex enzyme, and there will be accumulation of alpha keto acids in the blood, as we mentioned, and acidification of the blood, plus in the urine. So if you measure patient urine for the acid, it will be quite elevated, and this urine, since there is an keto acids, will get special smell. And this smell is something that gave name to this disorder. What is the name? Maple syrup urine disease, when alpha keto acid dehydrogenase complex enzyme is not working. That's the name maple syrup urine disease may confuse you, and maybe it will make you think that it's an easy disorder. No, it's not an easy disorder. It's quite dangerous. Patient can die early in life. Plus, there are a lot of complications, mental retardations, growth abnormalities, seizures, so very dangerous disorder. without treatment, patient will die soon or will end up in intensive care unit very early in their life. Please keep this information. You need to answer the questions later about this disorder, so I hope you'll be able to recognize the pattern of this disorder. What else is important here? What are the clues to understand this is the disorder? Before lab test is that special odor of the urine, special smell. This smell again is derived from alpha keto acid. Dehydrogenation. Okay, we talked about oxidative decarboxylation, dehydrogenation. Right, we talked about that. And the end product of branched chain amino acid conversion and modification is from isoleucine. We can get acetyl-CoA and succinyl-CoA. From valine, what we get is coenzyme A, so it's specifically glucogenic. And for leucine, we get ketogenic pathway, so we get acetoacetate or acetyl-CoA. They, in the end, give different compounds. Not all of them will give the same compound. So when we are talking about these three together, that's very nice because they go initially with the same steps. But in the end product is slightly different. Isoleucine, both valine glucogenic and leucine ketogenic exclusively. Please try to remember. Okay, folic acid is a carrier of 1 carbon unit. We talked before about the folic acid. We talked about the folic acid derivatives in the beginning, if you remember, and this folic acid derivate is the participant of the chemical reaction. It's not an enzyme itself, right? Okay, it's not an enzyme itself, but a derivative. Active folic acid can give us tetrahydrofolate, and this tetrahydrofolate is something you will hear a lot later as well. And now we can stop and talk about it. Tetrahydrofolate, derivative of folic acid. Folic acid, vitamin B9, and this vitamin B9 can be converted to from folate to give us tetrahydrofolate. What is the enzyme that is responsible for this conversion? Because we need a special enzyme for this conversion. This is dihydrofolate reductase. Please remember, dihydrofolate reductase, name of the enzyme that is responsible for the conversion. And this enzyme, dihydrofolate reductase, needs something to work, and this something is NADPH. Please don't forget. NADPH, required process, enzyme, let's say activation of folic acid. Activation will involve conversion of folic acid to tetrahydrofolic acid. Here you will get information about the nitrogen 5 and 10, that is carbon bound. Well, not necessary for you to remember in which carbons you have the binding, but you will see the name N5 and 10, methyl tetrahydrofolate. N5 and 10 methyl tetrahydrofolate is the name that we get from N10 and from tetrahydrofolate by the steps of conversion, and this is something that we will also talk again. Since this N5 and 10 methyl tetrahydrofolate is important, we saw that in the conversion of cysteine, methionine, homocysteine, if you remember, and in the part of SEM. SEM group is created by methionine, if you remember, and methionine was the methyl group donor. Something that is converting one methyl group from one to one molecule. That is giving it away, not converting specifically, but giving it away. And in this giving away of of carbon methyl group, we need our N5 and 10 methyl tetrahydrofolate. N5 and 10 methyl tetrahydrofolate as well as tetrahydrofolate is derived from vitamin B9, folic acid. Easy and simply as that. And I think you can see here one NADPH that is required and another NADPH that is required in the conversion process, and enzyme that is very important in the activation of folic acid is the hydrofolate reductase. Sometimes this enzyme is not working, and it means that patient cannot get active form of folic acid. That will cause different problems in your patient. I will see. Okay. We were talking about essential amino acids, mostly non-essential amino acids. At some point, we also mentioned these non-essential amino acids, for example, tyrosine, is derived from the essentials in majority of cases inside human body. It means that we do not need to take it with the diet, and we can just modify them from something that is already present in the human body. These modification processes is important for you to remember and memorize, and what are the enzymes involved in these modification processes is also important. So we mentioned briefly cysteine that we get from methionine. We mentioned homocysteine, but homocysteine is not a special type of amino acid, and tyrosine as a conversion from phenylalanine and methionine. Okay, and it's not the only one. We can see conversions of different amino acids. Before these essential non-essential conversions, you saw a lot of times alpha keto acids, right? And succinyl CoAs and acetoacetate, etc. That we can get it from the different steps of ketogenic or glucogenic or ketogenic pathways. Now let's try to look at it, how exactly we can get alpha keto acids. So for example, very easy and very fast that we probably need to talk about is alanine. How alanine can be converted into glucogenic pathway to give us pyruvate, aspartate and glutamate. Again, very easy pathways, very common pathways, and extremely commonly used by your liver. So alanine, to be converted into pyruvate, just needs to lose one amino group, right? If you remember the chemical structure of alanine, it's NH3 group, COH, one hydrogen attached to the carbon, and one methyl group. That's it, right? So if you need to create from that pyruvate, you just need to get rid of this one NH3 group. How is that possible? By aminotransferase. Aminotransferase. You already know what is that. With the use of alpha keto acid, because without alpha keto acid, there will not be anything that will accept this amino group. So we need two compounds, alanine and alpha keto acid. You just shift position of the amino group, and what you get is pyruvate and amino acid. That's written amino acid, different amino acid that is received from alpha keto acid. Important enzyme involved in the process is aminotransferase, and this aminotransferase has a special name. It's called alanine aminotransferase because it works on alanine specifically. We have different aminotransferases. If we know the substrate at what it works on, then it has a special name. So alanine aminotransferases are working on alanine specifically, and they are found in human liver. Then we have aspartate aminotransferase. Now I will call them special names since we are discussing not a general process but a specific one. Aspartate aminotransferase will convert this amino group from aspartate into alpha keto acid to give us oxaloacetate and another amino acid. Again found in human liver. And glutamate aminotransferase. So maybe you've heard about AST, ALT, GGT. This is all of these three are shown here: AST, ALT, AST, GGT. So glutamate. Similarly, amino group converted, transported to the alpha keto acid gives us alpha ketoglutarate, not pyruvate, not oxaloacetate, but alpha ketoglutarate and amino acid. These all three are found inside the human liver, mostly in majority of cases, but not only. So there are some other tissues which have these aminotransferases and transamination reactions, specifically muscles, right? Why in the muscle? They also need glucogenic pathways, and they also need to get some pyruvates for the conversion processes to work, right? To work. And inside the muscle, there are a lot of amino acids and a lot of proteins, and that's why muscle can use their own amino acid, their own protein, without waiting for the delivery from the liver or from the bloodstream, in extreme cases, of course. So if there is an elevation of those enzymes, please now slightly follow this logic. These enzymes are located inside the liver and the muscle, and these enzymes are located inside the cell, right? They are not located outside the cell. It's not possible, right? You have this enzyme outside the cell because the process happens inside the in the cytoplasm, the conversion processes, and they are hidden inside the cell. Whatever is inside the cell is difficult to catch with the blood test. Do you understand why? Yes. Yeah, that was slightly exactly what I was going to say, slightly early. First of all, why we cannot check something that is hidden inside the cell? Because they are not in the bloodstream, right? They are not supposed to be, those enzymes are not supposed to be in the bloodstream because they are supposed to be hidden inside, or not hidden, but well, resting inside the cell. Liver cells are called hepatocytes, or skeletal muscle cells are called myocytes. Inside the myocyte, inside the hepatocyte. If there is an elevation of those enzymes in the bloodstream, it means that something was damaged and those enzymes leaked. This leaking is not normal. Well, at some point, teeny tiny dosage of leaking is fine because you know that all the time human body has some cell degradation, turnover, repetition, etc. They will repeat itself, they will degrade, create themselves again, and this is a kind of a cycle that we call life. But for that, it's fine, right? Teeny tiny level of these enzymes to be found in the bloodstream is fine. And we know exact number of those enzymes that if they are found in the bloodstream is considered to be fine. If the level goes slightly higher than desired, then we know that is okay. Then it already means that something was damaged, and the damage was quite high. So it's directly proportional to the level of damage. If a lot of hepatocytes were damaged, then numbers of ALT, AST, GGT will be quite high. And elevation, if it's too high, for example, I will give you a brief example. Level of ALT is something like 25 milligram per liter or unit per liter. So this 25 is the number that you are looking for. In your patient, this number can go up to 500, 700, or 1,000. If it's 1,000, so if the elevation is so high, 10-fold, 15-fold, you can already talk about liver failure. It means that a lot of hepatocytes died and there is nothing else left to work. That's called liver failure. Liver is a good, let's say it's a good organ because it has a really nice chances of recovery. Liver works really quickly to recover even with teeny tiny part of the liver. If it's healthy, can work and can do its job. But these levels of hepatocyte damage is shown with the blood test very nicely. That is why it's so important to know the location of those enzymes. Where are they located? Inside the cell, outside the cell, in the bloodstream, where are they supposed to be? because if you find it in the other location, it already gives you information that there is some problem, some disorder. I mentioned the liver. I haven't talked about the muscle. Skeletal muscle is kind of the same. We need to have those enzymes inside the muscle cell, inside the myocytes. So if there is a damage and death of myocytes because of different reasons, I'm not going inside the reasons to list it for you because it's pathology. But for biochemical perspective, if there is a damage for the myocytes, their content will leak in the bloodstream, and if the content is leaking in the bloodstream, you will find it as an elevation of transaminative enzymes. For example, ALT, AST. GGT, glutamate gamma transferase, is not that common to be found inside the skeletal muscle. So it's not specific for skeletal muscle. That's why don't remember it as together with skeletal muscle. Anyways, for your final or midterm exams, of course, there will not be question asking you what is specific for the liver, which one is specific for the skeletal muscle, because it's not listed there. It's slightly linked to probably more advanced topic or pathology. But just try to remember transaminative reactions, transamination enzymes inside the cell. If they are found in the bloodstream, problem. Problem is cell death or severe damage of the cell. Content is leak. This rule applies not only to transaminations and not only to transaminative enzymes, but any compound that should be located inside the cell. If they are found in the bloodstream, means that cell was damaged. So, for example, for skeletal muscle damage, we have another compounds to check, but now we are not talking about it. We'll talk about it later. So these transamination reactions, important for us to remember. Then amidation, not amidation reaction, but amidation in general. What is this amidation? Transamination means removal and adjustment to something else. Deamination means removal of amino groups completely, like cutting off the amino group, and amidation means adding this amino group. So, for example, glutamate by glutamine synthetase can be synthesized if we add ammonia to our gamma carboxy group. Amidation reaction, adding group of amino acids, adding NH2 NH3 compound to the molecular formula to get different amino acid, right? We are not only talking about degradation of the amino acids. We are talking about their conversion into different substances, into different molecular formula that are different amino acids, for example. How we can get it? By either removal of amino acid, transferring of amino acid, or adding of this amino group. This process, amidation, needs ATP because that's energy required process. You don't need to memorize any cofactors, just try to remember ATP as an energy source. Okay, then asparagine. Again, asparagine has amide linkage with the beta carboxy group, not the gamma carboxy compared to glutamine, but to beta. It's not that important for you to remember, but well, it's a amino group is attached to carboxy group is fine. And that can be formed from aspartate. So names are so similar, aspartate and asparagine. They are two different molecular formulas, but derived from each other, very, very similar. Just teeny tiny difference is amino group. And the enzyme that is responsible for conversion is asparagine synthetase. Not difficult, I hope to remember, right? Asparagine synthetase will synthesize asparagine. How it can do that? Where it's getting amino group? Glutamine. Amino group should be derived from something, right? And this something is glutamine. It works as a source of amino group, or as we call it, as a donor of amino group. right? Again, here we need ATP as an energy source. Amidation reaction needs ATP. It do not need vitamins, it do not need cofactors, but ATP. Proline. What we need to know about the proline, how we can get it, first of all, and is it essential? Proline is not essential. We can get it from glutamate with the conversions, different conversion reactions. Not important for you to remember the type of convertive reactions, but what is the source for proline? Yes. Serine, glycine, cysteine. We talked about cysteine, I think. I don't remember if we talked about serine. Not about the serine. Okay. What about the serine? First of all, how we can get our serine? 3-phosphoglycerate is the source, and glycolysis, or this is a intermediate product of glycolysis that can be oxidized specifically, and this is hydrolysis of a phosphate ester is important to give us finally serine. So what are the multiple steps? Of course, it's a multiple steps. First of all, 3-phosphoglycerate is an essential initial part. This 3-phosphoglycerate is derived from glycolysis, and then we need to create 3-phosphoserine and phosphate ester. Cleavage or hydrolysis will give us a serine. It's not the only step, of course. Something should also happen to give us a serine. This is transfer of hydroxyl methyl group. And if you remember hydroxyl methyl group donor, we are talking about N5, N10 methylene tetrahydrofolate. N5, N10. That was also this N5 methylene tetrahydrofolate derived from folic acid with these different steps that requires NADPH, 2 times NADPH. The tetrahydrofolate reductase. I hope you remember this one. That will work. N5 and 10 methylene tetrahydrofolate will work as a donor of 1 carbon, 1 methyl group donor, to give us serine. Glycine. Glycine is the quite simple version of amino acid. It has nothing specific about it apart from its size, quite small, and it's not essential amino acid. We can get it from the conversion processes that requires tetrahydrofolate as a carbon acceptor, not a donor, but acceptor. Enzyme is kind of similar, serine hydroxymethyl transferase. We talked about cysteine, so I think I won't stop here. They mentioned cysteine there again because N5 and 10 methylene tetrahydrofolate was also necessary for its conversion, and we know that cysteine is derived from methionine, non-essential amino acid. If your patient has some kind of deficiency of methionine intake, then patient will suffer with cysteine deficiency as well. So it's not like only methionine will be deficient. Just try to remember this way. If patient is not getting enough essential amino acid, the amino acid that is derived from the essential one will also be deficient. Straightforwardly, I think it's not difficult to first of all understand. Now, and plus memorize. Memorize what? Memorize that methionine gives rise to cysteine. And tyrosine, let's finish briefly with that. Tyrosine, again, non-essential, that is derived from phenylalanine, right? Phenylalanine, essential amino acid. How do we get tyrosine from phenylalanine? With the help of enzyme phenylalanine hydroxylase. Phenylalanine hydroxylase. Very, very important step, because if this step is not working, then your patient will suffer with the disorder that we call phenylketonuria. Please try to remember this phenylketonuria as a disorder if this step is not working. But this step requires oxygen plus requires hydrobiopterin. This hydrobiopterin tetrahydrobiopterin has something special about it. We need to synthesize tetrahydrobiopterin from guanosine triphosphate will be used in this conversion process. But if we do not create if we do not have tetrahydrobiopterin, then enzyme itself, phenylalanine hydroxylase, will not work. So the same disorder, phenylketonuria, can be caused by two reasons. One reason is enzyme does not work, some kind of inborn error of the enzyme itself. And another reason is deficiency of tetrahydrobiopterin, or TH4 as it's shown as an abbreviation. Tetrahydrobiopterin. Plus molecular oxygen is required, but well, it's not possible to get deficiency of molecular oxygen. Very unlikely. That's why we don't focus that much on molecular oxygen. You can more or less skip this information. Okay. Tetrahydrobiopterin is derived from dehydrobiopterin, right? Dehydrobiopterin. What do we need during this process? How can we get tetra from dehydro? First of all, NADPH is required, and the enzyme called dehydropyridine reductase. Another reason for phenylketonuria is when cofactor is not created because of deficiency in different enzyme rather than phenylalanine hydroxylase. This another enzyme that also might be deficient or somehow with lower efficacy is dehydropyridine reductase. Dehydropyridine reductase is an enzyme that gives us tetrahydrobiopterin from dehydrobiopterin. Is it complicated, or does it make sense? Are you following? All right, very nice. So try to remember, phenylketonuria is a severe disorder and it's not rare. That's why it's so important to remember. It's not a rare metabolic error, and we check a patient for phenylketonuria routinely. Every single baby is checked. So I don't know if there is anyone with a baby here, or if there is anyone who had a baby in the family, someone. Probably if yes, you know that every single baby that are born in the hospital are checked for metabolic errors. Couple of metabolic disorders, not many. In Georgia, we check for, I think, 7 metabolic disorders, not more than that. In US, they check for way more, 25 or more. I don't remember exact number, so I can't tell you exact number, not to lie. But number is very high. Part of it is everywhere, all around the world, is phenylketonuria. Every single baby is checked for phenylketonuria. And for maple syrup urine disease as well, but phenylketonuria specifically, because I can tell about the Georgian example. Every single baby before leaving the hospital. Do you know how many days babies are staying in the hospital? Yeah, after 72 hours they should check, but you know, maybe you have some general idea how many days healthy babies are staying in the hospital? 3. Maximum is 3 days. If the baby is healthy, if the mother is healthy, just 3 days. So before a baby leaves the hospital in these 3 days, baby should be checked. After 72 hours, yes. Why 72 hours? Because baby needs to first get the food. In uterus, babies are not getting any food, right? Food is derived from the bloodstream, so no eating. After they get food, how good their metabolic pathways are working should be checked routinely. It's a screening method, and screening means that you don't wait for signs and symptoms. You check everyone, every single baby, to give them special directions of their diet. So when we look about on the phenylketonuria or maple syrup urine disease, probably you see that those are essential amino acids and their metabolic errors in their metabolic pathways, right? How can we treat them if the enzymes are not available? Just the diet. Give them what? Diet modification, yes. So diet modification is the simple, very simple solution if you look at it from the medical perspective. You just tell your patient not to eat anything that contains phenylalanine, or for maple syrup urine that contains isoleucine, leucine, valine. Right? Very easy. From medical perspective, it's easy. For patient perspective, it's not easy because a lot of food contains phenylalanine, and for phenylketonuria, and a lot of food contains branched chain amino acids for the another disorder. It's difficult for the patient, yes, but with diet modification, you can completely avoid complications. Well, with very, very watchful diet modification, but you can avoid a lot of complication. Most importantly, babies are growing healthy, completely healthy, no growth retardation, no mental retardation, no acidemias, no hospitalizations, no infections, frequent infection, etc. You can avoid everything with the simple diet modification, but in the first place, you have to know that these babies need diet modification. That's why you have to check it in 3 days after birth. Because if it's delayed, if the treatment, I mean diet modification, if it's delayed, then there will be reversible changes to the brain. And once there is irreversible changes, nothing will help. If if patient's brain is not um, developing well, later on with the help, you can't reverse the process. That's something we have to memorize. Okay, let's take our 5-minute break if it's possible, and then we'll Okay, so I think it's time to continue. Hope you enjoyed your 10-minute break. We were talking about tyrosine and how we get it from phenylalanine. I hope it also do not contains quite a lot of complicated steps for you. What you need to remember is enzyme. I haven't started about tyrosine. Okay, so for phenylalanine hydroxylase, something we need to memorize, and dehydropyridine reductase, something we need to memorize. These two enzymes very very important in the pathway of conversion of phenylalanine to tyrosine and tyrosine modification. If one of those enzymes are deficient, patient has a disorder. One of them, not necessarily to have both deficiencies, and basically it's quite unlikely to have deficiency of both enzymes at the same time. So tyrosine is itself non-essential, but depends on the dietary intake. It means that once, if your patient has phenylketonuria, disorder of the conversion pathways, then you need to supplement your patient with tyrosine because it cannot be converted to phenylalanine. That's important because if you do not supplement your patient with tyrosine and adequate dosage of tyrosine, then your patient will not be able to get something, and these somethings are catecholamines in the first place. I think we covered, or maybe not. From tyrosine, we need to get DOPA, from DOPA, dopamine, from dopamine, norepinephrine, from norepinephrine, epinephrine. This process will be abnormal or inefficient if there is deficiency in tyrosine. If that's a problem, then multiple neurotransmitters will be deficient, and in general, your patient health will be altered. Maybe I can't tell that exactly this will be the symptom because it's not like exact one specific symptom, but overall, your patient health will be will suffer a lot. So tyrosine supplementation while avoiding phenylalanine is something important. And one more thing, when we are avoiding some dietary compound, it's very difficult to avoid it completely in the first place because even with the smaller dosage, patient still gets this compound, but it's not a problem. With a smaller, maybe teeny tiny dosage of phenylalanine, your patient will not suffer. How you can check that, what dosage is fine and what is not fine? You have to monitor phenylketonuria level of phenylalanine in your patient throughout their life. The level should be monitored very tightly in a specific timely manner. If it gets elevated, the diet should get stricter. If it's below the norm desired level, diet can be more softer. So when we are talking about dietary restriction, we are not talking about complete restriction. It's impossible in the first place, right? In our world, it's impossible to completely avoid one compound. And one more thing, when we are talking about deficiencies, enzyme deficiencies, we are not talking about complete absence of the enzyme. Their activity is low, or their activity is not as desired, or Vmax is not that good, or Vmax is not similar to the normal healthy patients. But it does not mean that enzyme is completely absent. We are talking about deficiency of the enzyme, not an absence. If there was a situation in your patient, they have some kind of enzyme not present in their body, they will not be able to live at all, right? So it will be death in utero or miscarriages, spontaneous abortion, etc. They won't be livable. That's something we have to think of while we are thinking and talking about disorders. All disorders, does not matter if we are talking about phenylketonuria or are we talking about some other disorder. Okay, from tyrosine. Amino acid metabolism and their metabolic errors. What can be abnormal? Cystinuria is one of the disorders. It's quite common disorder, and I will tell you what is the cystinuria. Histidinemia, also kind of a mild condition, not that severe, but it's common in general population. Phenylketonuria, It's not rare. So I can't say that it's extremely common and you will see a lot of patients with phenylketonuria in your future career, but you will see patients with phenylketonuria probably for sure at some point. Methylmalonyl-CoA mutase deficiency. It's an average, not that rare, not that common. On average, you will find it. Albanese is slightly rare compared to the other metabolic errors, and homocystinuria, alkaptonuria, maple syrup urine disease, cystinuria, and cystinosis. Those are rare conditions. So cystinosis being the rarest, so that's why we won't focus on that. But whatever is more common, we have to know. Especially we have to know homocystinuria, alkaptonuria, maple syrup urine disease, phenylketonuria, and albinism. We'll cover those step by step. Do you know? Do you need to memorize their incidence and prevalence, not their numbers? How many people in the whole population is affected by those disorders? But how common are they? General understanding without memorizing number is must. Why is that must? You are going to make clinical. You are going to make some diagnosis, right? And before you diagnose your patient, you have to have the list of differential diagnoses in your head. If you do not know which disorder is more common compared to the other, your differential diagnostic list will not be accurate. You have to always think about the most common diagnosis to the least common diagnosis. When you create a list, you should start with the most and end with the least common. Because a lot of disorders can show similar signs and symptoms, similar characteristics, similar lab findings. How should you differentiate between these two? By thinking about the most to the least common. How you can do that if you do not know which disorder is common? It's impossible. That's why you need to know which disorder is common, which is not. Have you heard about incidence and prevalence, and do we know the difference between these two? Number of new cases, right? Incidence is number of new cases in the population, and prevalence is number of cases overall. So not how many patients will get this disorder in, let's say, 2018, but how many patients already have this disorder till 2018. How many live patients, not dead, of course, have this disorder. Of course, prevalence is a higher number than the incidence, but if disorder is getting more common, then number of incidents will rise first, and then number of prevalence will rise. Prevalence also is high for the disorders which have high rate of life. So, for example, if your patient has some disorder that will not kill them soon, then prevalence of this disorder will be high. And total number of patients with that disorder. Total number of metabolic disorders are not that important for you to memorize. For you to memorize, the most important thing is incidence, number of new cases. Because of metabolic disorders, killing your patient quite young. We talked about the screening and how screening is important to diagnose disorders. A screening of these metabolic errors for the babies happen inside the hospital before the discharge, of course, with maternal consent. True, but almost everyone gives the consent. It's not a difficult test. They do scratch of the skin, and skin scratch then will be diagnosed and sent for the lab test. Phenylketonuria, whose prevalence is shown 1 out of 15,000. 1 out of 15,000 is not a small number, and it's a prevalence, not incidence. Means that one patient out of 15,000 has this disorder. Not the first time, but they have it. One of the common conditions and deficiency of this enzyme, deficiency in this pathway is phenylalanine hydroxylase. It's more common than having deficiency of the hydrofolate reductase. We know this pathway, not stopping here. We covered this pathway. So pathway of tyrosine synthesis, catecholamine, and serotonin synthesis. For tyrosine synthesis, initiation is phenylalanine. For catecholamine synthesis, tyrosine is initiator. But pay attention to tetrahydrobiopterin. Tetrahydrobiopterin is involved in tyrosine synthesis as well as catecholamine synthesis as well as serotonin synthesis from tryptophan. I mentioned in the beginning that about tryptophan, that is a very important amino acid because it can give us neurotransmitter. What is this neurotransmitter? Serotonin. You've heard about serotonin, I think, in maybe in neuroanatomy, if you covered that. Okay, serotonin, important neurotransmitter for our brain. Plus, serotonin is not only in the central nervous system, but is found in the periphery, and serotonin will participate in allergic reactions. Phenylketonuria. We, I think, mentioned everything about phenylketonuria, but you have it checked once again. The efficient pathway is conversion of phenylalanine into tyrosine. That will be blocked. So everything behind the blocked enzyme, not blocked but deficient enzyme, it's shown in the fade color, means that it's deficient, not present, and everything about the deficient enzyme will accumulate. What is that? This is very important to understand. Here is the deficiency of enzyme. Everything below that, not present. Everything above it, elevated. This elevation is something that causes a problem in the human body. Phenylalanine will be converted, a lot of phenylalanines, if they accumulate, will be converted into phenylpyruvate, and phenylpyruvate will be converted into phenylacetate, and phenylacetate in bloodstream will cause acidosis because phenylacetate is acidic. I mentioned acidosis in case of brain chain amino acid dehydrogenase deficiencies, and when we were talking about isoleucine, leucine, valine, similar thing, not exactly the same, but similar thing happens in phenylketonuria. Accumulation of the phenylalanine will convert it into acidic version of phenylalanine that we call phenylacetate, from phenylpyruvate to phenylacetate, and this phenylacetate is a toxic for the bloodstream, causes decrease of pH, so we call it acidosis, and acidosis problem for the brain, and toxic effect on the brain. Very special clinical characteristic of phenylketonuria is patient has deficiency of tyrosine, right? With deficiency of tyrosine, patient has deficiency of melanin, because melanin is derived from tyrosine as well. You will see the pathway later. But if your patient has deficiency of melanin production, what do you think? It will be obvious. Sorry? Of course. Skin is pale, very, very white skin, and hair color is also very blonde. And eye color is bluish. So lack of melanin, not melanocytes, but lack of melanin itself will give special characteristic physical appearance of phenylketonuria. You will not see any babies with phenylketonuria with dark hair, dark skin. And by the way, their race does not matter. Does not matter what is their race. They will be whiter compared to their population. Plus, please do not mistake this white skin and white hair color to albinism. In albinism, there is complete absence of degradation of melanocytes. That's a different story. In albinism, and I will show you pictures of albinism, babies are not just pale, but they are white. Here they are just blonde and very light in their color. It's very typical. That should help you to make your differential diagnosis while you look at the baby. You can think of something. Then catecholamines will also be deficient, and this phenylpyruvate and phenylacetate will give to this baby urine special odor, and this odor is usually called mousy odor. So they kind of a smell, their urine kind of a smell like a mouse. So not a nice, not a pleasant smell at all. Okay. So this is called hypopigmentation, lack of melanin, since there is a lack of thyroid. By the way, if you initiate treatment later, if there is a restriction of phenylalanine and if you give tyrosine to the babies, their color will change. They will start growing darkest hair and their skin color, eye color, not that much, but hair for sure will darken. So this darkening is a good sign. Means that treatment is working and you did not misdiagnose your patient. You are on a correct pathway and correct way. CNS symptoms. This is extremely important one. This is basically what gives you disorder phenylketonuria. Just white color of the baby is not a big deal, right? No one will care if their babies are more whiter compared to their peers, right? Well, it's not a problem. Fine. They can live with that. They cannot live with the CNS abnormalities. Very important, mental retardation. Mental retardation means their brain is not developing well, so they won't start talking on time. You know, there is like special timing of baby development, right? If they cannot meet their milestones, means that they have retardation. Not talking on time, not walking on time, not calling their mothers, not having eye contact at the proper timing, because the first thing that you notice about the baby is eye contact. If baby can hear you, if baby can see you, if baby can recognize you, what you see is their eye contact. That will be problematic in the first place. Then we'll delay with speech, delay with motor function, delay with development in general, and hyperactivity as a hyperactivity that is coming from the CNS, and failure to grow. So when you look at these babies, first of all, they look blonde, all right, and very pale. Okay, plus they are smaller. They are shorter and their weight is also smaller. Very bad thing is that if mental retardation starts before the age 1, then their IQ will not increase at all. Well, slightly, but it will be very difficult to reverse mental retardation. You can reverse hypopigmentation. You can reverse the color, no problem. Tyrosine, catecholamines, that will work fine, but not mental retardation. We talked about the screening, so I guess that's it. From 24 to 48 hours before 72, basically, before you discharge your patient, you have to screen. There is a prenatal diagnosis as well. Prenatal means before birth, before babies are born. We can check for phenylketonuria. We don't do it routinely. It's not a routine test. It's not a screening test. But for phenylketonuria, if it's a genetic disorder, right? If patient relatives or parents or peers or siblings had a phenylketonuria, then it's better to check them for phenylketonuria. The mutation can be multiple. A lot of different mutation can alter phenylalanine hydroxylase enzyme, and some of the common mutations are genetic. That's why we have to check. We can check prenatally if there is a case of phenylketonuria in the family. Treatment, diet. We talked about this. Special diet, difficult for the patient and their family, but not difficult from medical perspective. Maternal phenylketonuria is something that we also need to pay attention, because if you treat phenylketonuria on the patient very rapidly and early in their life, then they will live very normal life, apart from the diet, of course. But their development will be fine. Their reproductive system will also be fine. So your patient with phenylketonuria can get pregnant without any problem, and this pregnancy is not dangerous for the mother, but it's dangerous for the baby. Why is that dangerous for the baby? Because it can cause maternal phenylketonuria syndrome, babies might be affected if they do not control their level of phenylalanine in the body. Because I mentioned diet, yes, but this diet with a timeful watching of the phenylalanine level. We have to watch the phenylalanine level all the time. And if my mothers get busy or I don't know, forget about checking their phenylalanine level, and if it gets higher, they can get some symptoms, not maybe severe, but these phenylalanine, pyruvate, and phenylalanine acetate can cross placenta barrier and cause symptoms from the fetus without having any disorder of the fetus itself. So it's slightly complicated. Think about it. Maternal phenylalanine is high, means maternal pyruvate and phenylacetate is high. That is crossing placenta barrier and is causing the same symptom for the baby if they had phenylalanine hydroxylase deficiency, but without having phenylalanine hydroxylase deficiency. It's not necessary for the baby to have the disorder if mother also had it. The only thing is maternal disorder can affect the baby in utero, because in utero, whatever mother has in their bloodstream, babies will have the same. Because for the babies, there is no alternative pathways. What it can cause for the baby. Babies of phenylketonuria mothers who have phenylketonuria. Mental retardation, similar to phenylketonuria because of obvious reasons. Congenital cardiac abnormalities, because this phenylalanine will work as a teratogenic for baby's organs. Mostly the most affected organ will be heart. Cardiological abnormalities in utero. After babies are born, they will not have a high level of phenylalanine, no problem, if they also do not have the deficiency of enzyme. But without deficiencies, no problem after they are separate from their mothers. But the thing is, if they already had a mental abnormality, mental retardation or abnormalities of their CNS function and cardiological abnormalities, cardiac structure is changed, then what you can do, right? Then to reverse this teratogenicity is very difficult. That's why it's extremely important for the pregnant mothers who have phenylketonuria to watch and to check their levels of phenylalanine. Very, very important. Maple syrup urine disease, and before I go there, I would love to show you. Picture of the baby with phenylketonuria. This is probably the classical picture of the baby with phenylketonuria. Please pay attention to her. She do not look like a patient with albinism. She's not completely white, right? She has some color, but very, very, she is pale in general with the blue or green color of her eyes, and hair is also very light blue, light blonde. And her facial expression, if you look at her eyes, probably you will understand that something is wrong. This something is mental retardation looking at you. By the way, it's not a severe phenylketonuria. Probably it's not a severe case, but kind of a mild, because her color is also not that white. And her mental retardation probably is not very profound. This baby also phenylketonuria, but probably the baby was treated early in life. Compared to that baby, if you look at the face and facial expression, probably that baby was not treated on time. And what we have here, severe case of phenylketonuria, probably it's a severe case. Hair looks pale and pale blonde, and baby looks very pale. And this is how do we test for phenylketonuria. They will just take a scratch of the skin and test it. That's it. One drop will be more than enough. There are a lot of phenylketonuria babies. Severe case of phenylketonuria. That is, I think, before the treatment. This is after the treatment. Facial expression change. Strabismus is not the only problem. The facial expression tells you that baby has some kind of mental retardation before the treatment and after the treatment. Phenylketonuria in an African region. So if you look at this, I mentioned before that babies raised do not matter. They would have the same color. So if you look at the facial features, probably you can tell that this is baby kid from the African region. But pay attention to the color. Very, very light skin color and hair, completely blonde. Okay, that's all about phenylketonuria. I wanted to show you for you to memorize how it will look and make it easier for you to remember and then diagnose properly. Now we can move to maple syrup urine disease. I mentioned it multiple times. We already know what is that. We can now focus more on the clinical signs and symptoms. First of all, is it a common disorder? Not that much, especially compared to phenylketonuria. The prevalence of phenylketonuria was 1 case per 15,000. Here it's 1% from 185,000. It's quite rare. Autosomal recessive condition, deficiency in brain chain amino acid dehydrogenase. What will accumulate is leucine, isoleucine, valine, and their accumulation will convert them into keto acids, and this keto acid will cause a decrease of pH and acidosis. If you do not put your patient on a special diet, they will suffer with mental retardation, different physical disabilities, so inability to walk or to start walking, inability to talk, inability to have any eye contact or any muscle strength and mass, and maybe some seizures early in life. And if it's a severe case and you don't put patient on a special diet or even a tiny diet, then death early in their life. Phenylketonuria is a severe disorder, but maple syrup urine disease is even worse because patient condition can deteriorate faster since since these acids are alpha keto acids are even more toxic to the patient blood than phenylpyruvate and phenylacetate. Toxic if they accumulate in our bloodstream, toxic for the CNS and toxic for the different organs. Specific in maple syrup urine disease is this odor of the urine that has a syrup-like smell. In phenylketonuria, it was mousy odor. Please don't forget about these two. In maple syrup urine disease, is maple syrup smell. There are different classifications of maple syrup urine disease, classicals and not classical form. Not necessary for you to know the different types of maple syrup urine disease. Both of them will show signs and symptoms early in life. Treatment is the diet. Screening is mandatory all time, and of course it's screened almost all over the world. Another disorder, metabolic error, that I want to discuss with you. Quite well, it's not that rare, not common, something on average. It's autosomal recessive, but X-linked. Autosomal recessive or X-linked form as well is albinism. Probably you've heard about it. We have a lot of people with albinism, quite popular as well in our country. This is the problem of the metabolic pathway where we cannot get from tyrosine that's not shown, our melanin, and patient do not have melanin at all. Compared to the phenylketonuria when there is like deficiency. In albinis, no melanin at all anywhere in patient body. So melanin is not found in the skin, in hair, in eyes as well. So itself, it's not linked. This albinism is not linked to any other complications such as no mental retardation, no blood acidification, no inner organ damage, nothing like that. Because the problem is only melanocytes and only melanin is the not melanocytes, but only melanin is the problem. You can't convert it into melanin, and that's the issue. It's not dangerous disorder for the patient, especially early in life. It won't kill them. It won't leave them disabled. All right, but still, it's not a nice condition. The problem linked to albinism is mostly linked to the eyes because eyes are not protected. The melanin is a protection, right? Melanin is a protection for our skin. Melanin is a protection for our eyes. And if they get direct sunlight or some sunlight, they will get easily burnt all over their body and eyes as well. So it's very common for people with albinism to have problem with the eyesight or to get blind early in their life. That's why if you ever seen someone with albinism, they are wearing very dark sunglasses. So they have artificial protection. All the time they are wearing sunscreen because they will get easily burnt. Plus, burn is not a huge issue. Huge issue for them is that they are not protected from cancer. What cancer is that? Skin cancer. So they have slightly higher chances of getting skin cancer, of getting blind, getting eye damage. And the chances for the skin cancer is slightly high, yes, but skin cancer itself is very dangerous because it's very aggressive. So if patient will suffer from anything, the person with albinism, they will suffer with eyesight problems, burns, or skin cancer. If it's skin cancer, then early death will probably be there. We call it hypopigmentation because there is a loss of pigmentation. They have to avoid sunlight as much as possible. If they have to go outside, they have to wear protections. Skin should be protected with the clothes, and the skin part that is not protected, for example, face is not always protected, should be covered with sunscreen all the time. Does not matter is it a daytime or night. Well, not nighttime, but is it cloudy or no? Does not matter. Skin is not protected at all. Since it's found not only autosomal recessive but X-linked as well, you will find it's slightly more in the males, but you can find in females as well because of autosomal recessive distribution. We have complete albinism and partial albinism. Complete albinism means that the enzyme tyrosine negative albinism, there is a complete absence of enzyme that requires copper, and tyrosinase that is completely absent in the patient with complete albinism, so no melanin whatsoever. And in partials, there is some activity of the enzyme. This is classical picture of complete albinism. So no pigment at all, hypopigmentation all over the body. Please do not mix it with phenylketonuria. Plus, do not mix it with vitiligo, because in vitiligo there is episodes of depigmentation, areas of depigmentation. It's not the disorder. In albinism, everything is depigmented or hypopigmented, no pigments. And pay attention to this red color. What is this red color? Lack of pigment, nothing is covering up the eye, so you can see the red reflex of the eyes. If they are not wearing sunglasses, just the reddish color of the not protected eyes. And brows, skin, completely pale. Another metabolic error that is not that rare, is homocystinuria. I guess we briefly touched homocystinuria. Homocysteine is first of all derived from our methionine, but from homocysteine we can get cystathionine. If we do not have the pathway working all nicely, if we cannot get from homocysteine cystathionine, what will accumulate is homocysteine. What will be deficient is cystathionine. What is the enzyme deficient in that pathway? Homocysteine cystathionine beta synthase. Cystathionine beta synthase that requires vitamin B6. Vitamin B6 deficiency will slow down the process, but it won't be completely absent. So vitamin B6 deficiency cannot cause homocystinuria, but it can cause a high level of slightly elevation of homocysteine. If this enzyme not working, homocysteine will accumulate, and if homocysteine accumulates, there is a chance for your patient to get something. Do you remember what is that something? Yes. So vascular disorders. It's not like the patient will die straight away and babies will suffer from that, not that much, but the homocysteine will accumulate in their life, and it can cause early thrombosis early in their life when you do not expect them. In young patients, for example, 30 years, 25 years old person, you don't expect them to have any myocardial infarctions and strokes. If that is the case, probably some metabolic error is found there. So what is homocystinuria? Deficiency in enzyme cystathionine beta synthetase and accumulation of homocysteine. Plasma high level of homocysteine and low level of cystathionine. If you measure these two, one is high, another will be low. Okay. The last condition is our alkaptonuria. Probably I will give you another, next class I will show you some clinical presentations of alkaptonuria. This is again metabolic error, inborn error. It's really rare, not common for our patient at all. And what happens is an accumulation of homogentisic acid will accumulate if the enzyme called homogentisic acid oxidase is not working. If this enzyme is not working, then accumulation of homogentisic acid will give your patient not a severe problems, but something abnormal. This is accumulation of homogentisic acid as a dark pigments all over their joints and causing patient urine to also get darker, oxidized if it's left on the oxygen. Joint will be affected. It means that those patients will most probably visit rheumatologists or rheumatologists at some point because they will develop a lot of arthritis or arthralgias, a lot of pigments, homogentisic acid accumulation inside the joint. If you ask me why inside the joint, I will definitely have a trouble answering your question because we don't exactly know why there is accumulation inside the joint specifically. But it's not specifically joint, but where if the accumulation is happening inside the joint, then it will be symptomatic. If accumulation is, or if the homogentisic acid leaves through the urine, not a big deal, right? Who cares about the color of the urine? Dark urine, no problem. It's not a painful one. But cartilage and collagenous darkening and accumulation is a problem associated with pain, but no mental retardation, of course, no acidification of the urine, no abnormal development of the person, and it's not found in the babies. Usually, alkaptonuria will show itself after 40-45 years of age. You won't find it early in childhood. Okay, and no life-threatening disorder. You don't need anything special for this patient, and if they will continue to have their signs and symptoms, more or less throughout their life, but after 40, 50 years. For that, they don't have any signs and symptoms. If you ask me why, well, difficult to answer, but this harmagentic acid needs time to accumulate and to build up on the cartilage to first give you signs and symptoms. I guess that's all for today. It's not all about the disorders. I need to add some more disorders next time. But please pay attention to those. And see you next week. Also, next week, I think you already start your tutorials. So we can work on the disorders on your tutorial.